Welcome back to the Curbsiders Addiction Med podcast, where we use expert interviews to bring you clinical pearls and practice-changing knowledge on substance use disorders. I'm Dr. Carolyn Chan, and today I'm joined by my friend, Dr. Kenny Morford. How are you today, Kenny?
I'm great, Carolyn. Today, we're going to recap a recent episode on buprenorphine for chronic pain. This episode features Dr. Will Becker from Yale School of Medicine, production and graphics designed by me, and this episode was reviewed by Dr. Pyle Roy.
We learned a ton of great pearls in this episode, so make sure you check out the full-length episode. I think one of the main pearls I took away was to make sure that we have adequate time during each visit to assess an individual's chronic pain and long-term opioid use. So Dr. Becker actually recommended trying to get 30 to 40 minutes blocked off for this discussion and really hone in on the patient's pain and pain experience. So key questions you may want to include are, what does a typical day look like for you? How does pain limit you throughout the day? How is your pain and function changed over time? And be sure to tune your ears in for any declining function or sedentary lifestyle. If the picture is one of declining function, adverse effects from opioids, or a lack of meaningful benefit in the patient's own view, it implies either low benefit or absence of benefit from opioid therapy. And this may be a sign that it's time to start to rethink the treatment plan. So, Kenny, can you remind us how we actually diagnose opioid use disorder in patients on long-term opioid treatment?
Happy to. Yeah, so we diagnose patients with opioid use disorder using the DSM-5 criteria, so the same way that we would for any patient that we're assessing opioid use disorder for. A key point to remember, though, is that for patients who are prescribed long-term opioid therapy, the criteria of tolerance and withdrawal should not be applied. And that's because tolerance and withdrawal are expected physiologic changes that can develop in someone prescribed long-term opioid therapy. In Dr. Becker's expert opinion, he typically doesn't think that an opioid use disorder diagnosis is appropriate unless the patient clearly demonstrates loss of control over their opioid use. And a caveat to this is that the loss of control criteria may not be related to opioid use disorder if a patient is struggling while they're undergoing a clinician-driven opioid taper. So the key point here is to only assess for opioid use disorder when a patient is receiving their current dose of prescribed opioids. Carolyn, can you remind us how buprenorphine works and which patients with chronic pain to consider using this for?
Absolutely. Buprenorphine is a partial opioid agonist that has high affinity for the mu-opioid receptor. So it has a ceiling effect on respiratory depression and typically has fewer side effects than full opioid agonists, yet it can be effective for pain management. So for some individuals, a switch to buprenorphine from a full opioid agonist may actually improve their pain control and quality of life. So Dr. Becker provides us a couple situations where he thinks we should consider using buprenorphine for chronic pain. So first, consider it in patients who are no longer benefiting from full agonist treatment or experiencing active harms on long-term opioid therapy. He thinks it's also reasonable to consider in opioid-naive patients who have exhausted, all of the non-opioid and non-pharmacological pain management modalities. As well as he does note that he's more likely to use buprenorphine in older patients for chronic pain who are opioid naive, because he wants to try to avoid causing the development of opioid physiological dependence in younger patients. So Kenny, will you walk us through a little bit more, a couple of tips that Dr. Becker gave us on how to actually transition a patient who's currently on opioids to buprenorphine?
Sure. Yeah. So there are two ways to transition a patient from long-term opioid therapy to buprenorphine. The first is considered a traditional start, and this is where an individual stops the full opioid agonist, and then they wait for withdrawal symptoms to develop. If a patient is taking a short-acting opioid, they usually have to stop that opioid for about 12 hours before starting buprenorphine. And if it's a longer-acting opioid, patients typically need closer to 24 to 72 hours before starting the buprenorphine. Now, the second approach to transitioning these patients is called the overlap method, and it's sometimes also called the low dose method. With this approach, a low dose of buprenorphine is started while the patient continues their full opioid agonist. And then that buprenorphine dose is slowly up titrated every day until they reach a therapeutic dose. And at that point, the full opioid agonist is stopped. So this process usually takes about 5 to 7 days. And Dr. Becker told us that this is now his preferred approach. And he gave us some tips for how to use this method successfully. So first, he says it's really important to determine which buprenorphine formulation the patient will switch to by calculating the morphine milligram equivalence, or MME. He also recommends that we understand which buprenorphine products are covered by your patient's insurance to make sure they can access the medication, because there are a lot of different formulations and insurances often don't cover all of the available products. And finally, we want to make sure that patients understand this process by asking them to do a teach back of the steps that are involved. So you should listen to our full episode, check out our show notes for specific protocols on how to transition these patients using this overlap or low dose method.
And this has been another recap of the Curbsiders Addiction Medicine, bringing you a little knowledge food for your brain hole. Get show notes at thecurbsiders.com/addiction. And until next time, I've been Dr. Carolyn Chan.
And I've been Dr. Kenny Morford. Thank you and have a good day.